For. We'll be starting in just a moment. Okay, my name is Jason Moore, and it is my pleasure to introduce Matt Smith from Central Florida. And Matt, since we're starting a moment late, I'll let you just jump right into it.
Okay. You guys hear me all right? So my name is Matt Smith. I am a physiatrist. For those of you who don't know what that is, it's kind of a combination between sports medicine and neurology a little bit, and I did a little extra training in sports and spine. I do a lot of procedures for the spine. My clinic is called the Spine Health Institute. It's in Altamont Springs, Florida, which is just north of Orlando. I hear there's an Altamont around California, but that's not that one. All right, so the title of my talk is called More Than Bones, and the reason it's called that is because as a spine doc, most of my training and focus is on the bony part of the spine. My premise or thesis is that we're missing a lot of the spine when that's all that we concentrate on. So we're going to start off actually with a quote or a couple quotes. So this is one of my favorite authors, Nassim Taleb. I heard there's a rumor he might be here tomorrow. I don't know if that's true or not. Anyway, he's famously known for saying that you shouldn't quote people, but I'm quoting him, and it's from his book of aphorisms, The Bed of Procrustes, and it's modernity's double punishment is to both make us age prematurely and to live longer, and then we're all a bunch of contrarians, and Oscar Wilde, I think, shares some of that same spirit, and of course he's famous for saying everything popular is wrong. So one of my contrarian viewpoints is the way we look at spine as a medical profession, maybe, if not wrong, incomplete. So I'm going to pretend that we're all clinicians here, and I'm going to give you a patient presentation. So history of present illness. We have the typical gentleman that I might see in clinic, 45-year-old guy. He's coming in with low back pain around his right butt. Past medical history, he's got insulin-resistant diabetes mellitus, a little bit of sleep apnea, reflux. He's got some arthritis in other areas, a little psoriasis, maybe a little hypercholesterolemic. The social history, fairly clean living guy. He likes to eat the standard American diet. Functional history, more or less the same, doesn't exercise quite as much as he should. Review of systems, nothing too scary. When I say scary, I'm thinking infection and cancer, right? So I'm thinking pain that awakens you at night, unintentional weight loss, things like that. Nothing too scary. Vitals, he's a little overweight. He's not a weightlifter. This is not because he can squat 500 pounds. He's just a little fat. From his physical exam, kind of an average build, what you would kind of expect from your everyday guy. So get some x-rays, nothing too scary. We think this might be a little bit of sacroiliac joint problem, which we think probably happens maybe up to 15% of the time. How do you treat him? I get him into physical therapy, give him a little bit of ibuprofen, maybe a sacroiliac joint belt, maybe do an injection if he's refractory to all this stuff. You know, your kind of standard stuff. So I've done that, but have I fixed the problem? Let's look at another patient. So similar 45-year-old guy. This time he doesn't come in with butt pain, but he comes in with hand pain. He's got some red, kind of painful nodules on his finger. He's got a history of mitral valve prolapse, tooth decay. He's diabetic too. He's got all those same kind of standard things that we see in almost everybody. This is a picture of his hand. So he's got, I decided not to shave, so this little sticker's not sticking on me. Anyway, so tell me if you can't hear me. So he's got these little nodules. Now these are actually, right here, these are not painful, but he's got ones on his fingertips that are. So what do we say? Well, you got little painful things on your hands. Having pain's bad. Let's give you some things to fix that pain. Just don't use your hands so much, right? And we fix the problem. Well, no, we haven't. Because at least these things here are called Janeway lesions. The things on his fingertips are called Osler nodes. These are septic emboli from what's called bacterial endocarditis, which is where you get an infection in your heart valve, shoots out little bits of bacteria that get lodged in little capillaries in your fingers, and you're basically on the you're on your way to dying really fast. And so if I just treated this guy, I've missed this whole underlying pathophysiology of what's really going on. I've only treated the symptoms. My contention is that treating that guy's sacroiliac pain is very similar to treating this guy's endocarditis with just a little bit of NSAIDs. I'm only treating the symptoms of a much deeper pathology. And so for those of you who don't know the lingo, supratentorial is your cortex, and that's kind of medical lingo for saying if your problem's supratentorial, it's saying it's all in your brain. So there's a reason probably a lot of our back pain patients come to us, and it's not just because they're crazy, right? There's more than just a psychological reason. They come with a whole constellation of pain symptoms and other problems. And then a doc I know quoted Bill Davis, and he said, just fixing these symptoms is like fixing a leaky faucet when your whole house is on fire. So how did I get started? This is actually a picture of me when I was 19. This is adriamycin. I'm a cancer survivor. I had a football-sized Ewing sarcoma in my belly. And they always say you don't know what you have until you don't have it. I was a mediocre athlete. I was pretty active and whatnot, but it wasn't until this happened that I said, I'm going to start working out. I'm going to really get into that lifestyle that really values everything that I can do. Of course, this is like late 90s. Paleo wasn't around then. This whole kind of thing wasn't around then, but I discovered actually all that when I was in residency. But this is kind of what got me going. So I'm going to talk about two things in this talk. The first is kind of stuff you guys already know or at least already suspect, at least in regards to low back pain. It's not just due to mechanical pathology, but also a manifestation of the metabolic syndrome. And if you don't know what that is, I'll talk about it. And the second part is the best way to fix the bulk of low back pain, or at least address it, this chronic low back pain, which is the main thing I'm going to focus on, is to address the metabolic syndrome in addition to the mechanics, such as what Esther speaks about. And I'm going to talk about this with 7 parts, and I'll just